Assalamu alaikum wa rahmatullah. I'm Dr. Luma Fraihat, and our talk today will be about hospice care. Originally, hospice is a word that defined a place or an organization that provides care for people who are dying. And then they define hospice care that is a care that focuses on the person's last 6 months of life or less when the curative treatment is no longer an option. So first it was defined the place where the end-of-life people are taken care of, and then they define it as care of the patients who are in the last months of their life, 6 months of their life. Dame Cicely Saunders, which is a famous nurse in the previous century who started the hospice movement in the United Kingdom in the 60s, and the aim was to care of dying. She established St. Christopher's Hospice in London. And then Balfour Mount, he coined the term palliative care in the 70s. And this term was acceptable in both English and French, and he brought this movement to Canada. The origin of the palliative care is from palliare, which means to cloak or to cover. So they started the palliative programs in large healthcare institutions, and then it became a community as a freestanding and volunteer programs. But with time, these programs they gradually become one movement that aims to relieve the suffering and improve quality of life in patients who are living with or dying from illness. So the hospice and palliative care was going together. So the aim of hospice is to relieve the physical, emotional, psychological, and spiritual suffering, and to improve the quality of life of patients who are dying, and to help the patients and their families also to deal with these life-threatening and critical illnesses. So the hospice mainly focuses on the last 6 months of life, where the curative treatment is not an option anymore, whereas the palliative care, it's more broad. It can be performed on non-terminal patients, and it can be given to any patients who is diagnosed with life-limiting chronic illness. So to summarize, palliative care is provided to any patient with serious life-threatening illness, whether he's for cure or not. The aim is mainly for symptom control, and he still can be cured. While the hospice deals mainly with the patients with serious illness with short life expectancy and usually less than 6 months, whereas curative treatment is not an option, and the aim is mainly symptomatic control. For the Medicare payment, this is in USA mainly that palliative care is not fully covered, where the hospice care is covered. The hospice care, in addition to the places where palliative care are taken care of, like home, assisted facility, nursing homes, there is also hospice facility can take care of those kind of patients. Levels of hospice are either routine home care or continuous home care, inpatient general care, or inpatient respite care, depending on the requirements and the needs of these patients. So why hospice care is important? Actually, because of general population are getting old, and they suffer at least of one or more chronic illness that needs hospitalization, that cause decreased quality of life, that increase the mortality. And the chronic diseases in US accounts for 75 to 85% of healthcare spending, and responsible for the majority of deaths in the USA, for example. Types of housing, you will see whenever you are reading about hospice care. Actually, we have to define what are the types of housing that are there. There is assisted living, which are residents of these living places. They get help with the basic activity of daily living. They can be offered of some medication assistant or reminder of medications. Some residential care or assisted living, they have resident nurse or therapist that can help only with minor medical problems. It's private with gathering area where there is less abuse, and the payment is family mainly. This is again in USA as an example of the housings. Nursing homes, they are a cost-effective way that where the patients are taken care of with their medical problems and waiting for them to recover. An environment that is different or outside of the hospital. The problem that it's reported that there is problems with these nursing homes. It is covered in USA with the Medicaid, but the problem that the patients are more susceptible to malnutrition, dehydration, sores, and abuse. Or the patient can be taken care of in their own homes, where the home care provider can offer services depending of the patient's needs, like a skilled registered nurse or home care companion. And this type we see usually here in Saudi Arabia, that the family are themselves providing either a companion or nurses to take care of the patients at their end of life. So let us describe what are the phases at end of life, as we are talking about patients with a life expectancy of 6 months. So we have to know which phase they are in. Actually, in general, end of life phases are either phase 1, which is a life-limiting threatening illness with a life expectancy of more than 6 months. And here there is still a rule for surgery or chemotherapy or radiation with palliative intent. So here we have to control them symptoms in addition to put a plan for the advanced care. In phase 2, where there is life expectancy less than 6 months and where the PPS decreased, and here we focus mainly on quality of life. You can discuss the code status, you can discuss the place of care, you can involve the multidisciplinary team in the more effectively in this phase. And phase 3, where is the late phase in the end of life, where the life expectancy is less than 2 weeks, and the patient is said to be imminently dying, where they're more focused on the psycho-spiritual social needs of the patient and the families. And phase 4 is the day of death, and phase 5 is the bereavement, which is the 1 year following the patient death. So this slide also to emphasize the differences of palliative care and hospice care. Actually, you can say that end-of-life care and terminal care are hospice care, which can be a part of the bigger umbrella, which is the palliative care. Palliative care cares about any patient who diagnosed with a life-limiting or life-threatening illness, where the aim is symptom management and quality of life improvement, and where there is still a role for therapy. as whether curative or palliative. End-of-life care is the hospice care and the terminal, and involve end-of-life and terminal care, where the end-of-life, the illness is not curable. The life expectancy, as we said, is months to weeks, and mainly we are caring about the psychosocial part or aspect of patient care in addition to symptom management. And the part of this end-of-life care is the terminal care, which is ours today's, where the psychospiritual social support is important in addition to symptom control. This slide, though a little bit busy, but I can summarize. It showed the hospice palliative care admission criteria in Canada, and it differentiates between the admission criteria in the palliative community care and the palliative care unit and the hospice care unit. So the one in blue is the palliative community care, where there's a presence of life-limiting or threatening illness that required symptom management. Length of stay usually and the prognosis less than 12 months, and the goals of care are palliative care approach, where patient needs can be supported with combined caregiver support and the community care also. طبعا it can be cared at home, that's why it's a community care. And care needs usually are support devices, nursing care, and medical supplies and equipment, without complicated care. When you come to the palliative care unit, there's no prognosis criteria for admission. So there's no life expectancy of less than 1 year or more than 1 year. Once the patient has a need for palliative care and he has life-limiting or life-threatening illness that requires specialized palliative pain control and symptom management, which is complex and cannot be taken care of care at home, and then he can admit it to the palliative care unit. And usually they stay in until this complication resolved, like it's usually days and weeks. And the aim of palliative care unit is to manage pain, symptom crisis, and there is no requirement of DNR there in Canada. طبعا the palliative care unit is only kept for people with a complex need that cannot be taken care at home, like acute pain crisis, acute delirium, acute sepsis or infection, and special requirements like tracheostomy care, drains, BiPAP, but the patient still can receive active therapy during the palliative care unit admission. And the hospice care unit is the one in the green, where the life expectancy is weeks or less than 6 months in general, with the presence of progressive life-limiting or life-threatening illness, where the PPS or palliative performance scale is low, less than 30. And the patient is admitted to the hospice unit to care for the end of life mainly, and he must be DNR. The opposite on the palliative care unit, it's not a must there. There is something that prevent patient to be taken care of at end of life at home, or do not wish for home death, so he's brought to the hospice care unit. Hospice care is provided to cancer and non-cancer patients, and there is admission criteria that is different between these diseases, and it can be different also between the countries. For example, in US, the cancer patients has to be a PPS of less than or equal 70, with dependence in 1 and 2 or more daily activity living. There is progressive malignancy with metastasis, and there's supportive criteria also, like high calcium, cachexia, or recurrence post-treatment, and other things. So it can be different between different countries depending on what criteria they are using for defining life expectancy of life less than 6 months. For non-cancer patients, they use what we call FAST scale, and the patient should be advanced FAST scale, like he should be 7C or more, with at least one of more of the following: aspiration, pyelonephritis, sepsis, pressure ulcer, recurrent fever, decrease in caloric intake, and other things that suggested limited prognosis. So this is the FAST scale we are talking about. So he should be 7C to be accepted demented patient in hospice. So the 7C's ambulatory ability is lost. He cannot walk without personal assistance. Heart disease also has specific criteria for admission, like to be advanced stage NIHA class 4 with significant symptoms at rest, with inability to carry out even minimal physical activity without dyspnea or angina. Patient is treated fully and he has angina at rest with supportive documents like syncope, historic CPR, low ejection fraction less than 20. Also, AIDS has specific criteria like CD4 less than 25, viral load more than 100,000, and at least CNS lymphoma or systemic lymphoma, loss of body mass, lean body mass, end-stage renal disease, PML or MAC bacteremia or Cryptosporidium infection, and certain infections with a low PPS. Renal patients, if the patient is not seeking dialysis and the creatinine clearance is less than 10 cc per minute or less than 15 for diabetics, or if the creatinine is more than 8 mg per deciliter. The supporting documents are the uremia, oliguria, intractable hyperkalemia, or uremic pericarditis. Pulmonary also criteria is a disabling dyspnea at rest with little or no response to bronchodilator and decreased functional capacity with disease progression, recurrent hospitalization, and documentation of hypoxia and or hypercapnia with supporting documents for pulmonary and right-sided heart failure or weight loss. So there is specific criteria for each disease, and these criteria might be different between one country or another. But in general, the hospice care mainly take care about the patients with limited life expectancy of less than 6 months, where there is no more cure or thinking about curable interventions, and the aim mainly shifted to advanced care planning and psycho-spiritual social support of the patient and the family, and provide death with dignity. And the hospice care started also in Saudi Arabia, with many beds opened for these patients to be taken care of, with interdisciplinary team involvement, and inshallah it will develop more in the future. You matter because you are you. You matter to the last moment of your life. So hospice care provide this support to the patient and the family, and maybe provides the best care in comparison to the other services who maybe have more difficulties in prioritizing the needs of the hospice patients. Thank you for listening.